Hi, everyone. Welcome to our bi-monthly SCI in-service, where our residents discuss an area of spinal cord injury medicine that's of interest to them. This month, Dr. Katelyn Langford is going to be discussing functional electrical stimulation in spinal cord injury. Go ahead.
Hi, everyone. If you don't know me, my name is Katelyn. I'm one of the PGY2s. So as Dr. Abramoff said, I'll be doing FES and spinal cord injury specifically. So some of our learning objectives, we're going to define functional electrical stimulation, or FES, and its role in spinal cord injury rehab. We're going to discuss the physiological mechanisms behind it, explore some applications for mobility, upper limb function, and bowel and bladder management, and then review some evidence-based outcomes and challenges with it. So just a quick introduction to functional electrical stimulation. There weren't really any great definitions that I was finding. It is a subset of NMS, so neuromuscular stimulation. So it's essentially that, but it's stimulating multiple muscles in a coordinated sequence for the purpose of achieving a functional goal, hence functional electrical stimulation. So reading about the history of this, I thought it was actually kind of interesting. So e-stim was actually used in ancient Rome, where they were using shocks from torpedo ray fish to treat headaches and gout. And then it was brought back in the 1700s by Luigi Galvani, where they were successfully conducting electricity through frog nerves. And then in 1803, they used e-stim to reanimate a corpse. So this has been going on for centuries. And then in the 1960s, they really brought this into practice by treating foot drop in stroke patients. And that was 1961 was the first practical application of e-stim in rehab. In the 70s, I started introducing implantable stimulators, focusing specifically on hand function and ambulation. In the 1980s, development of non-invasive surface stimulators, and this was the introduction of the Para-Step system that is still used today, so that assists SCI patients with walking ability. In the 1990s, they started doing multi-channel systems for more complex motor tasks, and they started using robotic systems, integrating with FES for gait training. So it's kind of the hybrid models with the exoskeleton and STIM. In the 2000s, they started really going forth with the neuroprosthetics for grasp and reach. And this is when they developed late 90s, early 2000s with the sacral nerve stimulation for bowel and bladder dysfunction. In the 2010s, they brought back the hybrid systems, even at a greater scale with the FES and exoskeletons, more wearable devices. So that was using both devices kind of in a hybrid to get the best of both of them. And then now we're in the 2020s and we're in this era of artificial intelligence, neuroprosthetics, brain mapping, all of those things to kind of more focus on neuroplasticity and long-term recovery. So how does FES work? What's the physiology behind it? So essentially you have a remote. I think a lot of people have already seen this being used in the gym, but it's essentially you're putting electrodes on your patient. It's putting an electrical impulse from the machine to the patient if you're using like transcutaneous system. And then you're activating a nerve, which goes to the lower motor neuron. And this only works with patients that have preserved lower motor neuron function, meaning their upper motor neurons have been damaged. So then you get the muscle contraction and hence the functional movement with feedback and adaptation with sensory and even adaptation over time. So some of the indications for this, I know as residents, I've been getting messages from therapy, is e-stim okay to use? And at first I really didn't understand like what the indications and what the contraindications were for this. So really it's muscle atrophy, cardiovascular deconditioning, lower limb sensory or upper limb motor loss, bone degeneration, and even spasticity. But some of the contraindications, some of these are not surprising, which would be DVT, hemorrhagic conditions. Obviously, don't want to use this if your patient's bleeding, pregnancy, at-risk skin, cardiac failure, infection, malignancy, recently radiated tissue, tuberculosis, implanted electronic devices like a pacemaker or impaired circulation. If your patient has a vasculopath, you probably wouldn't want to use this on them. So going to applications, I'm only going to talk about a few of these. I think pain management is obviously its own specialty, and they use something quite like this. I think that would be more of a grand rounds application if I was going to talk about that. And I'll touch a little bit on neuroplasticity with bowel and bladder, but really I want to talk about upper limb function, lower limb function, bowel bladder, and improving strength and endurance with cardiovascular conditioning. So with upper limb function, we have surface, percutaneous, or implanted electrodes. I think the BioNess is the system that's kind of most widely used for the surface electrodes. So that's exactly what it sounds like. It just goes on your arm and it'll give you the electrical impulse through the device, but it doesn't break the skin. Now, the percutaneous electrodes, the NEC is a perc system that was used to stimulate muscles of the hand, arm, shoulder, based on command signals from switches, voice, sip and puff, joysticks. But this was really developed in Japan and has only been used for research purposes. They didn't commercialize this at all, unfortunately. And then we have the implantable system, which was the freehand. So this produced a functionally strong grasp, where that was no longer able to be utilized prior in C5 and C6 tetraplegics. They did a couple studies on this population specifically, but unfortunately, this was withdrawn from market due to business and financial reasons. I think that was withdrawn in the 2010s, which was quite unfortunate. Similarly, the lower limb function, this can also be broken up into the surface, percutaneous, and implantable systems. I know in a lot of our patients, we just had a spinal cord injury that he was trying to use his BioNest system for some foot drop, and he was doing great with it. So that's a surface level, just like it would be in the upper limb. And what I touched on, it is an older system, but the Parastep system, this is all FES, and this can be seen in the top left-hand picture. I think in the 80s and 90s, they were using this. So this is all E-stim, and it assists patients in walking function. And then I included up on the right-hand side, that's kind of a hybrid system with kind of the uh, exoskeleton and BioNest-like uh, device, I should say. And I wanted to kind of bring up about some drawbacks to these, and a lot of that has to do with muscle fatigue and the control of joint trajectories, where patients are really easily fatigable, especially when they've been chronically ill with a spinal cord injury in the ICU for weeks, if they're a polytrauma, things like that. There's also no implantable systems that are available commercially in the United States. They are approved in Europe, though, unless I wasn't able to find one that has been recently available in the US. I think the papers that I was reading, as of like 2018, there wasn't an implantable one on the market. But the combination of the functional e-stim technology and the exoskeletons, like I mentioned before, that has been really promising in gait compensation, rehab, and that kind of brings both of the world of like robotics and e-stim together to make a really good device that's a little bit less heavy than just having a regular exoskeleton, and patients have been doing really well with that. Now on to bowel and bladder. So this is, I'm going to talk about mostly the sacral stim, implantable stim. So some of the contraindications for any type of bowel and bladder device would be active or recurrent pressure ulcers, sepsis, or obviously the pacemaker. So specifically in the spinal cord population, this is a question that we're always asking our patients, how are you voiding? How is that going? And frequently they have the inability to empty their bladder voluntarily. This can be due to neurogenic destructure overactivity. So this occurs as involuntary bladder contractions during filling, and that can lead to low volumes and incontinence. That isn't necessarily most of the spinal cords, but detrusor sphincter dyssynergia, or DSD, that's discoordinated simultaneous contraction of the detrusor and the external urethral sphincter. So that's leading to higher bladder pressures, which can result in vesicoureteral reflux, and that leads to kidney damage. And kind of before modern medicine, this was a leading cause of death in patients because it can lead to really horrific hydronephrosis, pyelonephritis, all of those uh, really horrible things that can lead to death. So some of these devices that are available, the Finitec Brinley system, so that's a sacral anterior root stim. So this is an e-stim controlled by an implantable pacemaker like device that drives bladder and urethral sphincter contraction. Um, so this specific device allows patterns that can empty the bladder, and it can lead to bladder emptying, like kind of in spurts. So it's mimicking your own physiologic voiding. This device can improve quality of life. However, the big drawback is you will probably have to do a select dorsal rhizotomy, because that will eliminate undesirable sphincter reflexes and bladder contractions. So that's a big a con to this device. And then there's a Vocare device, but one that I was mostly reading about was a Medtronic InterStim. So this is extradural stimulation of the sacral nerve roots, but they're not entirely sure how this one works. They know that it does improve bladder function. It can provide significant benefits, but further studies are going to be needed because the mechanism of action is not necessarily uh, clear. But in kind of like bigger picture, there's been a lot of studies on bowel and bladder function and these implantable stimulator devices and how they're decreasing residual volumes. Some are even having neuroplasticity with patients that are actually able to void after a few months by using these on their own. And these are mostly case study based. I haven't seen any like randomized control trials or anything like that. So it's just been a few patients that have had these studies undergone, but it seems like there's a lot of room in the future to continue these studies. Then in terms of cardiovascular exercise, there's multiple of these bikes. This is a MyoCycle home bike. So this is a $15,000 bike. For the home setting, they have clinical bikes as well. So basically, this is just allowing you to get your heart rate up, things like that, which is going to improve cardiovascular health. They've done a lot of studies on this. It's increasing your O2 uptake. You get a better ventilation rate, and uh, they've done, I think I mentioned like 3 studies where you have your peak O2 increasing by 103%, and basically patients are just doing really well cardiovascularly when they're using these bikes at home. Patients training 2 to 3 times a week for 6 months had an increase in power uptake. So basically, it's just a really good thing for cardiovascular fitness. One of the big drawbacks that I did see with e-stim, functional e-stim, is autonomic dysreflexia. Obviously, if you're, inducing something painful or something a little bit uncomfortable below the level of the injury, you do have the risk of having autonomic dysreflexia. And there were kind of some competing studies showing that these can cause autonomic dysreflexia, but also that they can attenuate some of the AD during functional e-stim. So I think certainly some more studies need to be done in terms of bigger population, not necessarily case series or case reports, but to see if that actually is a contraindication if you have a patient that is really having a propensity to AD, if e-stim is going to help or hurt them. So in terms of future directions, I think future and bowel bladder, I think given these current hypotheses of these unknown mechanisms of action, but it's involving central activation and excitation of the micturition circuitry. I think that there could be an interesting future of kind of promotion of plasticity at the level of the spinal cord and like long-term effects of these spinal cord stimulators on bladder function. There's been a ton of animal studies, but I think bringing that forth with more human studies would be super beneficial. I think long-term, like we've been really good with studying these short-term and in animal models, but we certainly need some long-term carryover. And then we're kind of in this era of AI and neuroprosthetics, where I think this sect of research is going is a brain gate is one device that's basically an implant in your brain to help with stimulating. And I'm not going to talk about that really now, but more AI in the future for sure. And these are my references. And this is Lando. Any questions?
Any questions, anyone? Comments, thoughts? So, when is the best time do you think to start like using these following a spinal cord injury? Did you get any sense of that in your readings?
So it seemed like it was a lot of, obviously out of the acute phase of the injury, but I wasn't really getting a timeline of when the best use would be. I would think it would be in rehab immediately after injury, but no one really commented on that, what I was reading.
Yeah, I don't have a great answer for that either. I think it's never really too early to experiment with some of these. Some of the more invasive ones, you'd probably be a little bit more chronic if you're thinking about like the Finley Brady system, which isn't even available in the US anymore. If you're thinking about like implanted devices, again, a lot of this isn't available. But for the ones that are totally external, I don't see any harm in trying them pretty early. And then this is another area I haven't seen a lot of research on in the past. I'm wondering if you found anything in your studies. What about the long-term use? Do patients who start using these devices tend to use them for years and years? I kind of get the sense that maybe besides like the Bioness for foot drop, maybe not, but I'm wondering if you saw anything on that.
So I saw the Bioness. There was a sleeve that was very similar to the Bioness.
Mhm.
And so it was just like lower profile. But I think people are using the bikes a lot,
Mhm.
just like in their home if they're able, of the SES status to be able to afford one.
Mhm.
Um, there were some papers that were on like the psychological dependence of these devices.
Mhm.
So that leads me to think that there are patients that are using these really long term.
Mhm. Great. Well, I think, there's certainly, we're not utilizing FES, I don't think, in my opinion, to its full potential. And unfortunately, a lot of that's based on payers. It's hard to make a company that's sustainable when insurers are not paying for these devices. Because some people have really noted market improvement. I have one patient who has an old Vocare / Freely Braytech system. She was one of the first pediatric patients implanted. And actually, she's doing all this research because she did not have a dorsal rhizotomy. Her parents refused it, and it actually worked still pretty well for her. And it's been years since she's used it, so now they're doing um, all these studies to see if it's still possible to revive it. But again, unfortunately, it's no longer really an option for most of our patients.
Yeah, it was kind of disconcerting when I was reading that all these systems were available. They had research that was really promising, and then they shut down due to like financial slash business reasons. So that kind of is terrible for the spinal cord community. But
It seems like lately, and who knows how this will change in the future, Medicare is starting to push a little bit on the limits of like what could be offered uh, through Medicare funding, which is really key for a lot of this technology to really be sustainable. At the same time, it has to be sustainable for the patients and something they're going to use. Not like oftentimes I'll hear that like, oh, I used it for like a few months and I really seemed to help at first, and then over time it kind of stopped helping. So we'll definitely see. Well, Dr. Langford, thank you very much for the great presentation. As usual, these presentations will be available on the resident lecture YouTube channel. So thank you, and we'll talk later.